Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Welcome, everybody, to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
Hi. Let's talk more adjuvant trials, James. Let's talk CheckMate 238. But first, maybe a few quick fires. Okay, let's talk food choices. Are you a still water or sparkling water person?
Don't really care, but probably sparkling.
Okay. Chocolate, milk chocolate, dark chocolate, white chocolate?
Kind of all of the above, depending on the mood. Yeah, I think one of the advantages of dark chocolate is you'll eat less. So you know, but I think there's a place for all of them. But I'm kind of a binger, so opening a packet of milk chocolate or something like that is probably bad for me. Well, I know it's bad for me, but anyway.
I'm getting the sense you don't like, very much like me, you don't like these binary choices. It's like it's not an either or. There's often there's a space and time for everything, I think. Yeah. And what about a question you asked me, dog or cat?
Definitely dog. We have a dog. Growing up, I had younger siblings, but my parents, my mother was really not keen on pets at all, allergic and stuff like that. So I didn't really grow up with pets, but we got a dog in the lockdown here, whenever that was 3-4 years ago, which many people did at the time. There's a whole big story about that. I don't know if it's the same in the US, dogs being bought in lockdown and then not being properly looked after and unwanted anyway. And we got a dog then. And, I think the price of dogs had, doubled or trebled at the time. No, really. Maybe I won't go into the figures, but the dog cost about 10 times more than I was expecting. Not double, about 10 times more. But but it's been great. I've really enjoyed it, and it's a bit cliched. And actually, Martin Gore, my friend and colleague, always used to say, and it's true. If you've got a dog and you get home from work, the dog's always pleased to see you.
Yeah, that's not really. Right.
Yeah. So you get that kind of, almost uncritical affection, and maybe, that's no bad thing, maybe. Especially at the end of a long day.
Long haul. Yeah. If only men were like this, right? Yeah. Just kidding.
I think that would be. We might need to cut that.
Okay, well, let's talk CheckMate 238, landmark study. Obviously, this was an industry-sponsored study. Why don't you take us through the study design, James? You were one of the authors on this.
Yeah, I think fairly straightforward design. Palpable stage 3 melanoma, so 3B3C, and then a few patients with so-called stage 4 NED, no evaluable metastatic disease. So generally will have had surgery. And actually, that's quite an interesting subject in its own right, but I won't labour that, in my view anyway. I won't labour that too much now. And then really a simple randomisation to IPI-10, a standard of care at the time, FDA approved, if my memory serves me correctly, versus nivolumab for a year. So that's the quick summary. Primary endpoint, relapse-free survival. So I can say that, for us in the UK, we were delighted to have access to an adjuvant treatment for these patients because we didn't have access to IPI-10. There hadn't honestly been that much usage of interferon historically anyway. So, we obviously have these patients in the clinic. We know the risk of relapse of palpable stage 3 is extremely high. So for us, it was very easy to recruit into the study.
Can I ask you why you didn't have access to IPI-10 if the EORTC 18071 study had reported by then?
Yeah, well, the EMA didn't approve it. And, I'm not, and I don't think I was party to any discussions about that at the time. But, these are complex considerations, I think, and regulators are obviously looking at benefit, they're looking at risk. And there also has to be a desire, I think, on the part of the manufacturer to actually push to get a reimbursement. And it may be that there were several issues there, but I don't know honestly, but it never got approved. So, God.
And in light of OS benefit, it's still not available for you to access?
No, so I think BMS make IPI, and I think events had overtaken honestly by that stage. CheckMate 238 read out. I'd have to think exactly when it read out. I think it was maybe ESMO 2017, 2018, something like that, when Jeff Weber presented the data. So that was a pretty quick readout, and to preempt a question, I think a clear benefit in terms of relapse-free survival for nivolumab over IPI, bearing in mind as well from the EORTC 18071 trial that already knew that IPI-10 had an RFS and an OS benefit over placebo. So if you like, another notch up. And then the tolerability, we all know, of a year of adjuvant treatment with anti-PD-1. I say to the patients, whenever I'm talking about single agent anti-PD-1, 85% of people won't have major side effects, a bit of tiredness, bit of itch. So I guess that's the sort of the background. The trial's got quite mature follow-up now, is the other, I think, quite important thing. We published the 5-year data, I think last year or the year before last. It's in CCR actually, along with some other analysis, and the 7.5-year data I think was ESMO maybe last year. So my take home from this, and the sort of the top line, is that the RFS benefit unsurprisingly hasn't really changed. The toxicity profile hasn't really changed. We don't really seem to be seeing late signals of side effects, and that's probably a whole subject in its own right, but we don't. And we're still not really seeing an overall survival benefit for Nivo versus IPI. But, that's kind of the crux of it. And it comes back to the fact that we know that IPI-10 of itself had a survival benefit. So if that does, can you therefore extrapolate that nivolumab does? It's a question, not a statement. And then the other thing, just to say, there's a bit of modelling out there as well, actually asking this exact question. If you compare the ORTC study with the CheckMate 238 study, does Nivo have an OS benefit? And so I think with all the modelling stuff, honestly, there's a load of different caveats which we don't need to labour. But for me, the modelling does at least suggest, shall we say, that there's if you like, an intrinsic OS benefit for Nivo. And before I stop talking, I'll also say that for me at least, we're talking about Nivo here, but had it been a year of Pembro, I'm not expecting any. I regard the drugs as interchangeable, really.
Yeah, I think that's the running consensus. What do you make of the forest plot if you were to look at the different subgroups of this study? Is there any subgroup that stands out? This was one of the adjuvant trials that took that resected stage 4, as you mentioned. Anything of note?
Yeah, I think honestly the hazard ratios are all in the same sort of ballpark, and I think you do need to be a little bit careful when we're looking, the numbers go down statistically, 3B, 3C, stage 4 NED. There's an obvious question and an obvious comparison. But, for me, if you look at the hazard ratios and confidence intervals, they're consistent. But, maybe to make my point about stage 4 NED, there's a few trials out there which have asked these kinds of questions in stage 4 NED. And I guess my beef with stage 4 NED, if you want to call it that, is about heterogeneity. And that's cliched, but true, because, what 2 patients with stage 4 NED melanoma are the same. And for me, there's a big issue about tempo here. There's quite a big difference, I think, if you've got someone who's got a metastatic deposit at one location, which you can deal with surgically, let's say, after a long interval, versus someone who's actually relapsed relatively quickly. And it's probably a general soapbox of mine that we have prognostic scoring systems in cancer, and we have all sorts of other things. But most people in clinicians who are seeing patients, have a really good feeling for tempo that I don't think is captured well in any of our scoring systems. We all know that things happening quickly is probably bad, right? But I'm not belittling the importance of anti-PD-1 monotherapy, let's say, in stage 4 NED melanoma. I'm just saying that patient selection for treatment is really, really important. And I worry with people who've got stage 4 NED that they're just about to develop some really bad stuff on the next scan.
Yeah.
And that if I give them single agent anti-PD-1, I wished I'd treated them with, say, Nivo. And, there's a trial that, that we could talk about a little bit, but maybe another time.
Yeah, I mean, Easter egg for maybe a future episode we can lay there. What's interesting is that these stage 4 resected NED patients are significant. I mean, as I go through this, one of these CheckMate 238 publications, it's patients with resected brain metastasis or fully treated brain metastasis. So I think, much to your point, the the feeling that most oncologists will have is that the tempo of that patient's resected stage 4 is different than somebody who has a contralateral nodal involvement stage 4 or distant soft tissue.
Yeah, I mean, I would say as much as that, almost different diseases. I mean, it's the same
Yeah.
disease, but it's behaving incredibly. And so then that's my point about heterogeneity, really. But
Yeah.
nevertheless, the patients are in the trial and the
Yeah.
data of the data, and we see a benefit. So that's
Yeah.
important. And it's basically a pretty well tolerated treatment. Just
Well,
maybe, yeah, go
yeah.
on. I was going to
No,
say,
no.
a couple of other notes, I suppose, on CheckMate 238, and these are the things that come up in clinic and are going to be rarer subtypes of melanoma, acral
Right.
and mucosal in particular. And there were a few patients actually with acral and mucosal melanoma in there. And then how do you deal with that in the adjuvant setting? So this is actually, I think in clinic it's quite an important question.
Right.
I think most people would agree from that trial and others, and this is my kind of rule of thumb, I think, for acral and mucosal, that the sensitivity to checkpoint inhibitors is A, less, and B, probably about 2/3 of cutaneous melanoma, ballpark. I mean, roughly speaking. So then if you're thinking about acral, assuming it's BRAF wild type, which it generally will be, but not always, what's the benefit risk of adjuvant anti-PD-1? And so actually the benefit risk probably isn't the same as a cutaneous melanoma because the upside is not as big. And so in clinic, and I may have said this to you before, one of the patterns that we still see a lot of, and we used to see it in the old days, is the person who's had an high-risk acral melanoma, they'll have had adjuvant anti-PD-1 treatment, as BRAF wild type, and then they still recur loco-regionally. And then we have these patients without visceral metastatic disease, often BRAF wild type, they failed adjuvant PD-1, massive unmet medical need here because we don't have loads of great treatments. You could treat them with ipi-nivo, you can do surgery, you could do TVEC, maybe loco-regional treatments. But that's my comment about acral. And then mucosal is the way I tend to sort of think about mucosal in clinic is partly based on the natural history of mucosal melanomas, which certainly in the pelvis are generally aggressive in my experience, and I think the data supports that. And so let's say we've got someone in clinic who's had a pelvic mucosal melanoma resected, rectal or female genital tract. I would, at the first meeting with the patient after surgery, just, they'll have probably had major surgery, they're still recovering. We talk a little bit about risk of relapse, and we talk a little bit maybe about adjuvant anti-PD-1. And then I deliberately don't rush in that situation. I deliberately get a set of full restaging scans, including MRI pelvis and brain and CT or PET CT. And then I would tend to see the patient about the 10-week mark. And if they haven't relapsed, and many patients will relapse on that first set of scans, then I say, well, look, actually, and this comes back to tempo, doesn't it? This is a reasonable thing to do. And I'm not sure everyone's giving adjuvant anti-PD-1 for mucosal, but I think it's reasonable. You discuss it with the patients. We know that there's sensitivity. There are a few patients there as well in the trial. The confidence intervals are probably wider than the screen, but that's kind of how I see it.
Let me pick up on a couple of things you said there. It is important that 238 included mucosal and acral, but let's be very clear, it was 3% of the population, right? Each of those groups had about 30 patients in them on a study of 900 patients. So less than 3% of the study population, although fairly, that's about the incidence rate. So that's probably reflective. I think the SWOG study also had a small number of mucosal acrals, but none of these, much to your point, the confidence intervals are wide, they cross one. It's really hard to know if these therapies are beneficial in those patient populations. Meanwhile, if you have these phenotypes of melanoma that are metastatic or distant, you certainly have a bigger arsenal, I guess, as we all do, whether it's cutaneous or not. And I am very aligned with your thinking, though I guess I hadn't sort of overtly said it, which is I sort of need these patients to declare if they are early metastasizers. So, because at that point, I have much more of an arsenal. I have combination therapy to use. If I use adjuvant PD-1 and you recur because your cancer was already going to recur, I'm not even sure if I've changed your biology a little bit by giving you. So, I'd almost rather sit tight. And if you're cured, you're cured. And if you're not, recur so that I can use bigger therapy on you where the magnitude of benefit is more clear for me and where the real need is clearer. So I guess I'm very aligned with your thinking, and it goes exactly back to that tempo thing that you're discussing, which cuts across all phenotypes of melanoma, cutaneous, mucosal, and acral. But perhaps what you're saying here, and maybe if anybody in the podverse is listening, maybe what we need is a dedicated trial for mucosal acral where we compare, say, single agent to combination, or combination to placebo, because we're really lacking. We're really not sure what to do for these patients. And instinct would tell you there is probably an intervention we could do for some of those that could be curative, additively curative, for those who are not already surgically cured. I like that.
Yeah, I think those are all good points. I think we're pretty much on the same page. I mean, I've got a heavy heart about this whole thing, honestly. And trials are great. I think the difficulties would be small numbers and sort of interest, I think. I mean, an academic study maybe, but then it would take a long time to recruit.
Mm-hmm.
Then you have the quote unquote risk of, changing standards of care, which we could maybe come back to another time. And then you might have the sort of physician disposition as well. If you're actually randomizing to placebo, I suspect some people might not be happy with that as well. So there's a lot of things to consider there. So honestly, I'd be surprised, if
It
that
won't be
happened anytime soon.
done. Yeah, it won't be done. Alternatively, our melanoma community is really collaborative and really linked up, sending around large database spreadsheets where we could say, why don't you just populate, if you've treated an adjuvant mucosal or acral patient with adjuvant PD-1 or other, why don't you fill this in? But, it would be hard to really get at the benefit of combination there because I'm not really sure who could use that therapy. But yeah, all good points. Well, what do we want to close with CheckMate 238? I mean, this is really a landmark study. It's got long follow-up, as you said now, active therapy versus active therapy. It really established the use of adjuvant anti-PD-1. It was the first study to do so. Anything else you think we need to say on this study?
No, I think that's it. And I think, separately we'll have a discussion about Keynote 054, because I think that,
Yeah.
it's important to understand that study and the differences and the similarities. No, thank you.
Last question to you is, when will we see OS from CheckMate 238?
Yeah, I don't know. We've got 7.5 years of follow-up at the moment. So I don't see the trial being analysed beyond 10 years, honestly.
Okay.
So maybe we'll see where we are in a year or two's time.
Okay. Sounds good. Well, thanks, James.
Thank you.